Thank you. We have heard about resistant schizophrenia. It is something we see very frequently in our daily practice. About 2/3 of our patients are resistant and they have residual and episodic schizophrenia. We know that most of them have resistant schizophrenia. About 80% of our patients are in the resistant group. What should we do with these patients? We have tried all the possible combinations of medication. What shall we do? What kind of solution can we find? We need to add different types of treatment, such as community support, etc. We don't have this modality in Turkey, but we know that in order to avoid the harmful effects of symptoms, social and community support activities have been very helpful. We must also be careful about non-compliance. We know that this is a chronic disease. Non-compliance of the patient must be avoided. You have to give compliance treatment. Sometimes parenteral drug administration could be recommended. When we start with parenteral drug treatment, some of the patients improve. We need to educate the family. Most of these patients have to receive treatment at home. And most of the patients are unable to accept the treatment, or they don't have the possibility of receiving treatment. That's why they are non-compliant, and that's why the disease becomes chronic. Most of these people have to learn to live with their symptoms. They have to survive with their disease, and they have to improve their quality of life by dealing with their symptoms. The most important thing they have to do here is to give them some occupational therapy. The patients have to work on something. They have to be occupied. We know that from the early period of medicine. Most people believe that occupational therapy is most important in decreasing the negative effect of the disease. Social activity is also a very important factor. Most of these patients are isolated from the society, and as they are isolated, their symptoms, severity of their symptoms increases. And we give social treatment to schizophrenia patients. We should not expect that social therapy is to create a miracle. We have to explain schizophrenia to the family and to the patient. We have to say that it's a disease. It's an organic disease like hypertension or diabetes. So if we define it as hypertension, how can we give them mental treatment or social treatment? You have to define everything very carefully, and you have to explain it to the patient. Most of the chronic physical diseases have a negative impact on the mental state of the patient, and that will have an impact on the prognosis of the patient. Should we intervene in the mental status of the patient to slow down the prognosis of the disease? Yes, of course. There are many studies which indicate that this is possible. Non-compliance in hypertension or diabetes can be as serious as non-compliance in schizophrenia. When we recommend mental therapy or social therapy, our objective is to be able to keep the patient as a compliant patient. When you don't show interest in the patient, and they will be non-compliant. If we start early treatment and we continue supporting the patient, then the loss of functionality will be limited. Mental and social therapies must be taken very serious. During different stages of the disease, there is the prodromal period. There is a period when the patient is in remission, when the patient is improving. After that, there's some remnants. The patient is either improves or becomes chronic. In the general population, most of our patients, about 70% of them are chronic patients. Mental social therapies should be started as early as possible. And cognitive behavioral therapies, family support, etc. should be given to patients who are in remission or who are receiving treatment already. And they have to be supported by different modalities of treatment. The social functionality may be increased, quality of life may be improved, PANSS score will be improved, and they will also be feeling more satisfied with themselves. These are objective criteria which indicate improvement of the patient. Mental and social therapies should be started when the patient is in the acute period. You have to establish a relationship of trust with the patient in order to improve the quality of the treatment. So social treatment is not something that is very difficult. It should be part of our treatment modalities. When we first meet the patient, we have to give the patient parenteral treatment or perioral treatment, but we should start mental therapy and social therapy at the same time. You must also educate the family of the patient so that they know how to deal with relapses and with crises. The family should be able to adapt themselves to the changing conditions. All these will help the patient to preserve some functionality. In the early period, the yeast period, the improvement is 75%. Let me repeat it once again. In 5 years, there is a relapse. In atypical psychotics, we know that they are more acceptable to the patient. The patients are more compliant with atypical antipsychotics. But when you look at the data you see on the table here, you can see that in a study with classical antipsychotics, 75% of the patients are stopped taking their medication, and with atypicals it's 75% in 18 months. This is due to the specific characteristic of the patient. When you look at the disease in general, no matter what medication you give, the patient will stop taking the drug. So at this point we have to understand the importance of social therapy or mental therapy. We can only treat a very limited number of our patients. Our objective is to try to decrease the severity of the symptoms. Of course, we have to do something. We have to try to treat the patient, even though we know that we cannot help them recover full functionality. Imagine one of your relatives, someone in your family is a schizophrenia patient. Do you think only medical therapy is sufficient? You would need to reach your doctor as frequently as possible, and you would require a more comprehensive treatment approach. That is, of course, a request of the patient and the family. And I think it is one of the rights of the patient that concomitant complications such as anxiety, depression, and drug abuse must be taken into consideration. These patients are very sensitive to stress. They have to be They have to gain a specific role in society. They have to be able to live alone so that they can deal with their symptoms. The patient should be able to have control over the disease. You must understand that this is a biological disease. The patient should do his best in order to overcome the negative symptoms, and he should receive support from his family. A flexible treatment approach would be indicated. Most of the patients have problems with insights, they have ADD, they have excessive sensitivity to stress, they are also violent, they have depression, they have substance abuse issues, and they have issues with stigmatization. The patient stigmatizes themselves. Sometimes the family does that also. But these are not patients who come to us, to the physician. They are the patients who are brought to us. So we have to go to their home to treat them effectively and efficiently. Here we have data about 492 patients. Most of them are schizophrenic. Most of them are bachelors. They smoke. Most of them have been violent in the past. Most of them live with their family. They have symptoms. Major depression is also seen in some. More than 50% are unemployed. 25% have attempted suicide, and body mass index is 70%. 1 of every 4 patients has tried suicide. They don't receive family support. 1/3 are non-compliant, and 65% have been hospitalized. This means that 35% of the patients have not been hospitalized. Most of these patients, let's say 35-40%, have received therapy without being hospitalized. Schizophrenia patients have serious problems. They have serious lodging problems. I know some of my patients from the Sakarya region. They have been sent to Istanbul to receive treatments, and when they stopped the medication, they have to suffer attacks again. And the family is trying to find a solution, but at one point the family cannot bear this burden. The patients are unemployed, they're stigmatized, they are indeed a group of patients who have so many problems that it's not possible to deal with medical therapy. What we need to do is to supplement medical therapy with social therapy and mental support. We have to give them supportive treatment, cognitive behavioral treatment, cognitive rehabilitation, social support education, occupational therapy, family support, case management, and of course sometimes they need sanctuary or lodging. Most of the family of these patients are really unable to deal with the patient anymore. They have suffered so much that they cannot go on, and in this case we need social support for these patients. The responsibility for social services, for lodging, for medical treatment, you have to have a case administrator. A case administrator may regulate or lead the cases of maybe 10 or 15 patients. The case officer will be in charge of these patients. When we give them social support as well as medical treatment, we will get better results. And they need some sort of occupation. They need to able to continue with their education, they need to be made social so that the quality of life will be improved. The patient and the family have to accept the disease. They have to understand that this is a disease like any other. They have to develop the certain capacity for dealing with the disease, etc. Treatment modalities. A certain community therapy is required. It is an expensive method, but it's of course necessary. Stress should be decreased, the family should be educated, and stigmatization should be avoided. These are different modalities of social therapies, when added to medical therapy, have been found to be highly effective. Thank you very much.